Welcome to Mayo Clinic Q&A. Thanks for joining us today. I'm Dr. Helena Gazelka, and we are recording this on August the 3rd, 2020. When it comes to COVID, vaccines and testing continue to be really hot topics. Dr. Poland is here to talk to us about that today. There's a phase 3 trial, or at least 1 or 2 underway for vaccines, and there's news that a rapid in-home test for the virus may be coming up too. Thanks for joining us, Dr. Greg Poland, virologist and infectious disease expert at Mayo Clinic. Love having you here again today.
Thank you, Helena. Good to be with you. We do good work together.
That's right. So you're doing an awful lot of good work. Dr. Poland, tell us a little bit about what a rapid in-home COVID test would be like, and how would that work, and what effect would it have on the spread of the virus?
Yeah, so the background to this is really interesting. If you could find a highly sensitive and specific test that could be done at home, ideally non-invasively, for example, with saliva, or at a minimum, maybe a finger prick test, that would cost $1 or $2, ideally, to do, and where you could do it every 2 to 3 days. And the reason behind that is that people seem to be among their most infectious the 2 or 3 days before they know they have symptoms. So if you could test frequently enough, because it was easy enough to do, the test was good, it was inexpensive enough to do, you could detect that, immediately quarantine, and save exposing people around you. Now, the trick is sensitive enough, and that's really the hard part. Last week, the FDA released some industry guidance. They're basically kind of putting together an X Prize, is the idea, and trying to help companies develop assays like this. There's a couple of ways you could do it, as I mentioned: a finger stick, a swab, saliva. Any of those would work as biologic substrates to detect the virus, not the antibody, but to detect the virus, and then be able to self-quarantine, as I say. The problem with it is that so far, other than PCR, no assay has really demonstrated great sensitivity and specificity. Having said that, in a test like this, because the idea would be that you would test frequently, meaning it would have to be cheap enough, you don't have to have super high sensitivity and specificity. It needs to be a decent enough test, but not the same high quality clinical grade test that we would do, for example, at Mayo. So it's an enchanting idea. It fits with the modeling that's been done, where if you can test frequently enough, that you could actually start to dampen down, if people would quarantine, you could dampen down cases. And that, as you know, would be huge. We basically are in a situation far worse than when we locked down in March and April. It is basically raging out of control across the US. And we're going to have to do innovative things like this, in addition to convincing people that they've got to wear masks when they're outside and socially distance.
That's really sobering, Greg. You mentioned 2 things during that explanation that I wanted to ask you if you would clarify a little bit. Sure. One is that you said this test doesn't detect antibodies, so that would mean that it was for people who were infected at the time that they took the test?
Correct.
And then the other thing is, you mentioned 2 words, sensitivity and specificity. Could you explain a little bit for our lay audience what we mean by those terms?
Yeah, so sensitivity is the chance that the test would be positive if you are infected, and specificity meaning the chance that the test would be negative if you aren't infected. So you want to know the true state. If you're infected, you want to know that with high probability. If you're not infected, you want that test to be negative with high probability.
Now let's switch a little bit over to vaccines, because obviously you're talking about how we need to be socially distancing, we need to be wearing masks, we need to be cautious. But what we're really hoping for is that a vaccine will come along, be effective. And there are some vaccines in phase 3 trials. What is meant by a phase 3 trial, and how long does it take to get results from something like that?
Those are great questions. Phase 3 trial is really the last phase in the development of a vaccine before it goes through licensure. After licensure, then we do so-called phase 4 studies, which are really just attempts, once you're giving it now to hundreds of thousands and millions of people, to catch any side effects that you didn't in phase 3. So phase 1 has tens of people. Phase 2, maybe 100 or 200, something like that. Phase 3, usually thousands to tens of thousands. So the two big phase 3 trials right now are designed to determine efficacy and safety. Efficacy meaning, does it protect you against infection? Two of them are occurring. In the US, across 90 sites, the Moderna mRNA vaccine trial is occurring. They will enroll 30,000 people, 10,000 who will get a saltwater placebo, 20,000 who will get the vaccine. They won't know which one they've gotten. Across Europe, Brazil, and other locations, the Oxford vaccine will be tested in the same way in about 30,000 people. So at the end of that, what you'll know, hopefully, is did the vaccine prevent either acquiring the virus or at least prevent disease or symptoms and complications from that virus? You'll know a little bit about safety, but you'll actually only know about significant side effects that occur about 1 in 5,000 times or more often. So for example, a side effect that occurred 1 in 10,000 times, you won't know from this trial. That will await phase 4 when it's more widely used. So these are really important trials. Now, as you might imagine, to enroll 30,000 people, they get their vaccine on day 1, 28 days later, they get a second dose, and they're followed for 30, 60, 90 days. You're talking about typically years before those results get published. In this case, it will be months. So under the normal regulatory full licensure of a vaccine, we would not have that vaccine until sometime in 2021. Whether there might be an emergency use authorization occurring earlier, and there's a lot of pressure for that, as long as the vaccine was found to be safe and had some degree of efficacy, that would be a possibility before the end of the year, but I'm not counting on that.
Greg, I know that you're an expert in vaccines, and I'm curious, how do companies who are developing vaccines find tens of thousands of people to test them on? And are they people of all ages?
Yeah, so what they're going to be doing is testing adults and adults of various ages, but they won't yet be testing pregnant women or children, and that's a problem. As we've seen, children absolutely can transmit this virus, and widely so. And for good reason, pregnant women are very concerned. Who wouldn't be in regard to having a child, during a pandemic like this? So at the current time, they're not included in these trials. The Moderna trial will occur in the US, the Oxford trial outside of the US. And for people that are interested, they can go to a website, coronavirusprevention.org, and sign up to be a volunteer in the study, which of course is very helpful in trying to get this done. But it's an interesting thing. There are a lot of people who would sign up for a study like this, myself included. And then a lot of people who say they wouldn't take a vaccine like this. The current polls are that 20% of Americans plan on rejecting a vaccine. A number of about 30% are unsure. And the remaining 50% say they would take a vaccine. Well, we can't develop a vaccine unless people are willing to enter these studies and take a vaccine. So it really is important.
I find that absolutely fascinating. I wasn't familiar with those numbers, but that is really amazing to me.
Yeah.
When you think of the public health, the changes that have come from vaccines, I just think of something like smallpox, which is essentially eradicated around the world, except in labs, I think.
Let me just
vaccines, that's amazing.
Yeah, let me just mention that website. I'm not sure I said the full name, but it's In fact, I wrote it down. It's at coronaviruspreventionnetwork.org. Coronaviruspreventionnetwork.org.
That's great. And that's for people who might be interested in a vaccine trial.
Or otherwise healthy adults who are interested in enrolling in this trial.
So Greg, you're always good for some new news on COVID-19, and we know there's a lot that develops on a daily basis almost. What are we learning now about our own immune system responses to COVID-19?
People shouldn't be surprised, and I know it's frustrating. People shouldn't be surprised that when you're studying something brand new, the studies will be conflicting. And the reason for that is, you know, Helena, you might be studying a certain kind of patient group, and then I study a different kind of patient group or in a different setting, and we get different kinds of results. That's to be expected. What's important is that as we go on and we learn more and we look at larger and larger groups of subsets of patients, we begin to have confidence in what those results are. So where we are right now is understanding that, yes, these antibody levels, particularly after mild or asymptomatic disease, fall very rapidly in the course of months. With moderate to more severe disease, that decline, that drift in antibody levels is lower. But remember that there's also cellular immunity that's involved. So while the current marker that we would use for protection is neutralizing antibody, and we know that antibody drifts down over time, it doesn't mean necessarily that you aren't protected. For example, we know this well for us as physicians. Many of us got our hepatitis B vaccines when we were in residency or medical school. 10, 15, 20 years later, you could test some of us and we would have no antibody. And yet we are protected because we have those cellular memory cells in our bone marrow that as soon as we see the virus, we start making antibody and protect ourselves. So 2 key points. You have to have those cells, and the incubation period after you get exposed to the virus has to be long enough that those cells can make protective antibody. We don't know yet whether that will be true, either with mild or moderate disease or with vaccine-induced immune protection. Those are the big questions. And in fact, that's, as we mentioned, that's one of the big questions that the phase 3 trials will answer. So I think there's a lot to learn yet about our immune responses. I think the other thing that we've really learned is, I don't even know how it got started, but there was the idea that kids don't transmit the virus. Well, you know, just the end of July reported this past week was a camp of kids 6 to 19 years old in Georgia. And of those they could test, 76% of them got infected. Now, these are campers and staff that had been tested by PCR in the 12 days prior to coming to that camp. All the staff wore masks, but the campers did not. And that's all it took. And basically, the majority of them got infected. Over 70% of them are having symptoms of fever, headache, sore throat. And those kids are probably safe. It's the fact that they're going to go back to families and communities, and the disease just, you know, spread out if they don't quarantine effectively. You know, this is very sad for us as healthcare providers. Over 3,000 healthcare providers worldwide have died from COVID, taking care of patients who have been infected. Over 500 in the US alone. A big study came out from England looking at 100,000 US and UK healthcare providers. And we have a risk that's 3.5 times higher than the general public in becoming COVID positive, because we are seeing and taking care of patients. The other thing is that the White House has come out with new estimates, estimating that in the next 20 days, somewhere around 30,000 Americans are likely to die from COVID. And this, It's flabbergasting. I mean, it's like standing there and watching people run into the pathway of a speeding train. We have got to convince them that if they don't wear masks and wear them properly, if they don't socially distance, they are placing themselves, indeed, jeopardizing the entire country in an outbreak that we have not been able to control. And the further consequence of this is because of that, this is very likely to keep going on and on and on. This virus will search out everybody who is not protected. It will have consequences that I think people cannot and do not understand unless we take the protective measures that we know to take. And I think this is, I guess this is amounting to a plea for how important this is. As physicians and nurses, we want to see people healthy. We don't want to be in the hospital like they are in Houston, making decisions about who's going to get a ventilator, who's going to get an antiviral drug, because there are more sick people than there are ventilators or drugs available. This is preventable if we do the right thing.
I had also seen the article about the children in Georgia, which made it particularly profound to me when I saw this morning that the Sturgis bike rally is still planned to go on in South Dakota, and they're expecting 250,000 people to attend that bike rally. And I thought, oh, well, that sounds like some badness waiting to happen.
We know very well from every kind of gathering where humans gather unprotected and undistanced from each other, that you markedly increase the number of people who get infected. I think the other consequence, and again, this is sobering, is there's now a very nice paper released by a group at the Rockefeller, an excellent institution, showing that the virus is indeed acquiring mutations that might make it evade plasma, monoclonal antibodies, or even potentially vaccine-induced antibody. So by having this virus infect thousands of people very rapidly, you increase the chance of this virus mutating. It might not cause any more severe symptoms, but what it might do is allow that virus, as it changes, to escape being killed by antibodies due to vaccine, due to monoclonal antibodies, or due to the fact that you got infected, 6 months ago. You might not be protected if this virus mutates. So this is one of those very difficult issues where the cure for this is we, not me. It's all of us doing everything we can and wrapping this thing up in a few months versus having this be a prolonged multi-year exercise in tallying up over 1,000 deaths a day because we can't seem to make ourselves do the right thing.
I told you I like to learn something new every day, and I had not understood that before about the rapidity, the evolution of the virus with increases in how fast it is passed from one individual to another. That's
exactly right.
Thank you for teaching me my new thing today. Did you have anything else you wanted to add for us here at the end, Craig?
I think the other thing that is beginning to be hopeful is that we are understanding more about the inflammatory part of the immune response to the virus. And in many cases, and this is again something people don't often understand, there's three aspects to what happens, what injures us and kills us from this virus. One is the virus itself. The second is the cellular damage that the virus does. So for example, a pneumonia, or causing blood clots, or causing the heart not to function properly. But the third one that people forget about is our own immune system's inflammatory response to the virus. And sometimes, and that's apparently what happens in these severe cases, is that our own body overcompensates in that inflammatory response and actually causes more disease. It's kind of a counterintuitive thought that our immune system, in some respect, can be our own worst enemy. And so what investigators are starting to do, and there are many trials now, are use some of the anti-inflammatory drugs. These are drugs, for example, that are commonly used in autoimmune disorders, and start studying those to see if we can, in selected cases, dampen down that hyperinflammatory immune response. You'll sometimes hear it called cytokine storm, and see if we can decrease the severity and the death rate by that. So I'm hopeful about that.
Well, that's a good positive note. And one of the very basic anti-inflammatory medications is a steroid like dexamethasone, which has shown some promise, I know.
Yeah, good point. Thank you for raising that. Dexamethasone in severe cases has definitely been shown to be of benefit. And not just dexamethasone, that happened to be the preparation they used, but steroid preparations in general.
Lots going on in the world of COVID. Thanks so much for being here with us today, Dr. Greg Poland, infectious disease expert and virologist from the Mayo Clinic. And thank you, too, for taking some time with us today.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.